Okay. Hello, MMOA crew. This is Dr. Samantha Chamberlain with the Modern Management of the Older Adult Faculty with the Institute of Clinical Excellence. I am coming to you live to talk about normal pressure hydrocephaly. So I kind of gave the answer already, but if you looked at the title, it was gait disturbances or difficulty walking specifically, forgetfulness or dementia-like symptoms, and bladder control problems or incontinence. And this may trigger like some dementia symptoms, some Alzheimer's pathology type things when you hear those three clustered together, but we really need to dive into those when we're talking with patients. So this is going to be a bit of a case study, but also here's a pathology that maybe we should know about. I don't know if we talked about it in PT school. If we did, it didn't stick. So I'm here to either remind you or inform you about this pathology that you may have not been exposed to or may have, and it slipped into the back of your mind like it did mine, or maybe it's just one of those things that you're not familiar with. So I really had no idea what the signs and symptoms of it were, and you can gather from the name that it involves some kind of fluid in the brain, probably not a change in pressure because it's normal pressure hydrocephalus. So I want to just start by reading you what the definition is from the Neurological Association page. And it says, normal pressure hydrocephalus results from the gradual blockage of the cerebral spinal fluid draining pathways in the brain. The ventricles enlarge to handle the increased volume of CSF, thus compressing the brain from within and eventually damaging or destroying the brain tissue. NPH, as it is known, owes its name to the fact that the ventricles inside the brain become enlarged with little or no increase in pressure. However, the name can be misleading as some patients can have pressure fluctuations from high to normal to low when monitored. NPH can occur as the result of head injury, cranial surgery, hemorrhage, meningitis, or tumor. Unfortunately, the cause of the majority of NPH cases is unknown, making it difficult to diagnose and understand. Compounding this difficulty is the fact that some of the symptoms of NPH are similar to the effects of the aging process, which is never the answer we like to, chalk things up to, as well as diseases such as Alzheimer's and Parkinson's. The majority of NPH population is older than 60, and many of these people believe their symptoms are just part of the aging process. Unfortunately, many cases go unrecognized and never properly treated or are misdiagnosed. So, of course, I want to dive into some of the symptoms of that, but I also looked on a couple of different other websites. That one specifically was from the American Association of Neurological Surgeons. On the Alzheimer's Association page and the Hydrocephalus Association page, they went on to say that approximately 700,000 people or adults have NPH, but it's often misdiagnosed as that definition mentioned with Alzheimer's or Parkinson's disease, but less than 20% of people with NPH are properly diagnosed with it. So that, and with the cause being greatly unknown, and some of the things that can occur, like causing it, is of course tumor or different things going on in the brain that block that drainage, but it can just happen without any known pathology behind it, and so treating it can be quite difficult, or diagnosing it can be, obviously easy, with those three primary symptoms being so similar to some other pathologies that we tend to start to think of in that 60, 70-year-old age range, that we really want to dive into what you can be looking for in the clinic and how you can play a big role in really helping some people out. So symptoms of adult onset NPH are headaches, nausea, difficulty focusing the eyes, unsteady walk or gait, leg weakness, sudden falls, irritability, drowsiness, change in personality and behavior, and seizures. The primary symptoms, so these are some of the first things to happen, or kind of those keys that a specialist is looking for, is gait disturbances, specifically difficulty walking, dementia or forgetfulness, and then bladder control problems as the condition progresses. So some ways that you can start getting this, if you start hearing those things, and I'm gonna tell you about a patient so you can get a good clinical picture here. But to diagnose, they're going to need to do an MRI or a CT scan. But the thing with this is you need them to be asking specific questions and probably get into a specialist that is involved in these behavior type of symptoms, because several brain diseases, including Alzheimer's, may cause brain tissue to shrink, making the ventricles look larger. But with NPH, the ventricles are so full that they enlarge, pushing against the brain tissue, but the brain tissue itself not shrinking. It is sometimes getting damaged by the extra cerebral spinal fluid, but it's not the cause of the ventricles increasing. The fluid pushing on the edges of those ventricles is what's making them enlarged. On clinical exam, this is where I said you want to get to a specialist. So a neurologist with experience evaluating persons with brain disorder that affects movement, thinking, and physical function is the specialist specifically listed on some of those websites. And then they can, of course, do cerebral spinal fluid test to predict if the shunt would help, like if placing a shunt would help these individuals, and or determine the shunt pressure needed. So a lumbar puncture with external lumbar drainage, measurement of cerebral spinal fluid outflow resistance, intracranial pressure monitoring, and isotopic cisternography is a few of the ways that they can kind of dive in to see if the cerebral spinal fluid itself is the cause for some of the issues that your patient may be having. It said that the benefits of the shunt shunt insertion are few and limited currently, but that brings me kind of to my patient that I've had for quite some time, that he got a shunt in the fall and he's doing phenomenally better. So let me share a little bit about this patient with you so you can kind of start to get a picture of what this person may as you treat them, because it's not as black and white as that definition makes it seem. So to tell you about this picture, the first episode of care, the first episode of care I had with him, I was actually treating him for back pain and knee pain. This was actually a couple years ago now, and he did get better. He was having a little bit of balance issues, but he did well on like the mini best test. He was able to react, like he was like mid to higher range, but he always could catch his balance. Like he would have loss of balance, but he would catch himself. So he did really good from a reactive stepping and those types of things. He could handle really well. And so that's, like I said, that's not even why he was originally referred to me. It was because of knee and back pain. And so as we would get to talking and as we built that therapeutic alliance, he also shared with me that he was having some incontinence issues, felt like he had to go to the bathroom all the time, wasn't making it to the bathroom, different things like that. He was seeing a urinary specialist. And so I kind of maybe brushed that off a little more than I should have, because I thought it was being handled. Like he had already been down that path. He was seeing that specialist, fairly frequently. They were trying different medications. So in my mind, it was being managed, by someone more equipped to manage it than I would be, because like I said, he was referred to someone because he had been having these bladder issues. He was seeing a specialist for it, like I said, and then he mentioned a few dizzy spells or stumbling. But when I asked if he was dizzy or if the room was spinning or if he felt like he was spinning, he said no, like he, in his brain, like in his head, he didn't feel woozy or dizzy. He just felt really unsteady and couldn't catch his balance all the time. Like he would actually take off spinning himself, like stumbling so much that he'd be turning in circles. And so that's when I started kind of diving into more vestibular type training and teasing out if it was vertigo, or trying to figure out why he was having these episodes, because it didn't really sound the way people typically explain vertigo. So yeah, I checked for it, but I was like, that it just doesn't fit with how he was explaining his symptoms and when it would happen and things like that. So he had been progressing, and I believe at this point we had taken a little bit of a break from PT. And then a few months later, he started back, and he was really frustrated with his bladder issues. None of the medications were working. None of the answers he was getting from his specialist were like beneficial to him. It was just kind of like a wait and see type of thing. No real direction there except for trying different medications every few months. And he wasn't getting any major results from that, obviously. So a few months later, I saw him. He was frustrated, and he was having more stumbling spells. He kind of would call them these spells. Like sometimes it would make him feel sick. So nausea sounded more in line with maybe vertigo. So we kind of went through that whole process again. I started incorporating more vestibular fitness, a term coined by our MOA crew, Alex Germano, within our physical fitness plan. And he really improved in his ability not to fall. He would still have these like spinning episodes. I'm seeing him currently, and he said that when it first started, his wife thought he was just showing off because he could just spin and spin and spin and not fall down. But it would take someone, like, as soon as he could get his hand on a stable surface, or if someone put their hand on his shoulder, he could stop. But until he had that stable surface to catch himself on, he would be spinning. And so we talked about that at the second episode of care that I had him for. And at this point, he had been sent to a neurologist, and she had ran some tests. Like, she had put him through some cognitive tests and some motor response tests and different skill tests for him, and then ran another test and then did it again. Unfortunately, the test wasn't done correctly and by her assistants and whoever was working with her. And so she was very frustrated. He actually showed me the like in his chart where she had emailed him and let him know that she apologized and that's not how it was supposed to be done. And she was very frustrated. But this led to, she thought it was accurate enough that she could send him to yet another specialist. And that's where this neurologist specialist came in that was able to drain some spinal fluid, did a lumbar puncture, drained some spinal fluid. And he said for those 3 days after they took, I think it was 30 or 50, I know it's a big jump, but I can't remember right off the top of my head, but they removed 30 cc's of CSF. And he said the next day when he woke up, he felt better than he's felt in like 4 years. He was not having any stumbling. He did not have to, like, he had full control of urination. He was not having any issues with incontinence. He felt clear-headed. He was focused. He was not forgetting things. Like, he felt like he could focus. He says he golfs a lot or hits golf balls in his yard. And he said he kind of tests himself of if he can keep focus on the ball and not get distracted by either traffic or bird or, squirrel, literally, then he knows that it's a good focus day. Like, if he can keep his eyes on that ball throughout his swing multiple times, he knows it's a good focus day. And he said he was having no problem with that for the 3 days after they drained that significant amount of fluid off of his, out of his spinal fluid. And then they went ahead, because he had such good results from that, they went ahead and added a shunt. Now, he's a little bit frustrated again because he had a different medical issue come up and it required an MRI. So they had to adjust the shunt. And then he thought that they turned it back up to where it was before that incident. But just last week, they turned it back up to where he was before that. And this past week, he started to feel better again. Like, he's not feeling as unsteady. For example, the week before last, I had him doing deadlifts, which of course creates that motion with your head. So it's going to make that spinal fluid be moving within your brain. And he had one of those, like, if the rail on the rig wasn't there, he would have been spinning, but he was able to grab and steady himself. And he had one other episode of that where I had to kind of place hands on his shoulder to give him that steady, like, we can stop, to give him that reference point. And then we did some of those same exercises, those same interventions this past week, and he had 0 of those, and they had turned his shunt up that Monday. I saw him that Wednesday, and he was already noticing that it was much better again, how it was like before he had the last MRI. So for him, in this case, having the shunt placement has made a very drastic impact on his life and what he feels like he's capable of doing without feeling so, not frail, but just, he didn't feel as confident in doing those things. And it was very frustrating to him because he felt like he could, except for he was having these like unsteady episodes and the bladder control issues. And all those things combined were making him have a hard time continuing to live the way he wanted to live. It wasn't a physically incapable. It wasn't some major underlying brain pathology. Yes, it involves the brain, but it's something that's obviously much more treatable than something like Alzheimer's or those things that we don't have a good grasp on yet as far as diagnosing and treating. So just food for thought. If you have someone with these 3 primary issues going on and they're either on medication for forgetfulness, or they said they've talked to their doctor about dementia, or they've been given the MOCA, or, they have these type of things or multiple doctor's appointments going on and no one's able to figure it out, or they're starting to talk about Alzheimer's, you might have them check about normal pressure hydrocephalus, because that sounds like a much, not necessarily easier to manage, but maybe gives them a little bit more hope that it's not their brain deteriorating so much as it's just they have too much spinal fluid. So I feel like that'd be a little bit more easier to handle as an older adult than some other pathologies that could lead to that. So you're looking for gait disturbances, like significant unsteadiness, especially with turning or tilting your head up and down, such as for like a deadlift, going up and down, where anything could be sloshing, not to put it like, a slushy, but where you could get some, like if you were to move a bowl of water up and down, how's that going to move within their head, or how's that water going to move? So you can kind of think of that. If it's anything that's going to make fluid move significantly and they're having unsteadiness with that, or they're having a hard time walking, this might be something that you start diving into. Are they also feeling like they're more forgetful? Something they may not tell you up front without you asking. So are they more forgetful? And then are they having bladder issues? That's another thing that just in my evaluation I ask about, just so that they don't have to feel uncomfortable bringing it up, but that especially males maybe don't want to bring up as frequently. Women, we just kind of brush it off as, oh, we expect it. Males tend to be a little bit more kept to the chest about that. Like they just don't want to talk about it, maybe in female presence. But that's something that you should definitely ask about as one of their healthcare providers. So gait disturbances, forgetfulness, and incontinence or bladder control issues are 3 of the primary symptoms of normal pressure hydrocephalus, which may be something that they look into if they're starting to get some of those diagnoses of dementia, Alzheimer's, even Parkinson's. He's got a little bit of a shake going on. But it has also gotten better since the cerebral spinal fluid has decreased. So something to think about. So excited to be here with you this evening. And just a heads up about some courses that are coming up before I get off here. Level 1, our online course, 8-week online course, will be kicking off our next cohort for 2024 on March 13th. So that's about a month away. So just giving you a heads up that in about 1 month, Level 1 will be starting up again. Level 2, you have a little bit longer, but just wanted to mention that May 16th will be the next cohort of Level 2. Used to be Advanced Concepts for the Modern Management Older Adult, is now Level 2. And then MMOA Live, we have several courses coming up. We have this weekend in Oklahoma City. Me and Christina will be there. February 24th, we have Gales Ferry, Connecticut, but we also have a sold-out course in Rochester, Minnesota. And I just mentioned that to say there's another course in Minnesota later this year. So if you missed that one, you might go ahead and jump in and sign up on that one, because those courses do tend to sell out. And then March 2nd, we have a triple header. We're going to be in Sparks, Glencoe, Maryland, Rome, Georgia, and Halifax, Nova Scotia, Canada. So we have a triple header that's also international, which is so exciting. And then March 16th will be in Newton, Kansas. So if you had hopes of seeing us on the road this winter into spring, then go ahead and hop into one of those courses before they sell out.